Good afternoon, everybody, and warm greetings from India, Delhi. And thank you, Rufus, for giving me this opportunity to present some of our work and some of the findings from India. You have heard throughout the morning that South Asians also are people, our population, where vitamin D deficiency is really rampant. So this is a perspective of Indians with vitamin D deficiency, and let's go forward. I'll be talking about the clinical picture of vitamin D deficiency in Indian infants. So a lot of them are actually symptomatic with vitamin D deficiency, and studies on vitamin D status, the seasonal trends and determinants in lactating mothers and infants, and pregnant women and adolescent girls. And I'll also be talking about some of the vitamin D supplementation trials that have been conducted in India. So before we go forward, I would like to show you like this is India. So in terms of distance from the equator, you can see that the southernmost part of India is very close to the equator. It's around 10 degrees north, and the northernmost part would be around 40 degrees north. So India is like fairly tropical and subtropical, and this red dot is Delhi from where I come. So it's at 28 degrees north. So just to give you a perspective that it's a tropical, subtropical country with abundant sunshine throughout the year, and still we have so much of vitamin D deficiency. So sunlight, you need various factors for sunlight to be effective, and probably just depending on sunlight even in a sunny country will not be enough, and supplementation is required. So despite abundant sunshine, vitamin D deficiency has been recognized to be highly prevalent in India from north Delhi as well as from the south Tirupati, which is 13 degrees north. So how do these infants manifest? You would all be familiar with rickets, but when we are talking about infants, remember that infants won't have all the typical manifestations. They won't have bow legs, they won't have wrist widening. These infants commonly have frontal bossing, they have a wide open anterior fontanelle, and they have rachitic rosary, as you can see in this infant. And if you do a radiograph, you can definitely see the clear manifestations of rickets, that is in the form of splaying, fraying, and these widening of the wrists, which can be seen in this picture. But commonly, how are these infants detected? It's not that they would present to us because of rachitic rosary. These infants commonly present with lower respiratory tract infections. Wheezy illnesses are very common, and this is how we pick them up, that they have a concomitant picture of rickets. Also, many of them present with hypocalcemic seizures, and at the time of examination we find that they also have evidence of rickets. So in fact, in Delhi, hypocalcemia has been recognized to be the commonest cause of seizures in infants. And it's not a medical rarity. We keep on getting infants with hypocalcemia day in and day out. So this particular study, this is data from Delhi. 60 consecutive infants who were between 15 days to 6 months of life, they presented with hypocalcemic seizures. They were enrolled along with their mothers and some control infants which were age and gender matched. And in them, what did the data show? Obviously, this is the infant group and this is the mothers. And in the study infants, they had hypocalcemia, hypophosphatemia, not really hypophosphatemia, but the phosphate levels were lower as compared to the control infants. These are the alkaline phosphatase levels, and you can see that they are much, much higher than the control infants. Vitamin D deficiency, as I told you earlier, is rampant. So even in the control group, the levels were around 9 plus minus 4 nanograms per ml. So that would translate to around 11 nanomoles. Sorry, not 11, 9 into 2.5. It will be somewhere close to 20 nanomoles per liter. And in the study population, the infants who presented with hypocalcemic seizures, they had such low levels, 4.9 plus minus 4.6. And secondary hyperparathyroidism was present. Look at the mothers. The mothers of infants who had presented with hypocalcemia, they also had elevated alkaline phosphatase. They also had very low vitamin D levels. This is in nanograms per ml. Even in the controls, the levels were not very high, but these mothers did have a significantly lower vitamin D as compared to the controls. And then another manifestation, which is thankfully not that common, but still we are seeing many of these infants, and we heard from speakers, earlier speakers, that in UK also there are babies, probably more from the South Asian community who are presenting with dilated cardiomyopathy. So hypocalcemia presenting with myocardial dysfunction and congestive heart failure. So this study was again published in 2010, and this was from a referral pediatric cardiac center from Delhi, and they did a retrospective case review. About 94 cases of which were referred to them as dilated cardiomyopathy were reviewed, and out of them they found that 15 had hypocalcemia as the reason for myocardial dysfunction, and out of these 15, alkaline phosphatase was high in all, hyperparathyroidism was present in 14 out of 15, and vitamin D deficiency was seen in around 80%. The median age of these infants was 2 months. So they were very young infants, from 1.5 to 5 months of age. They had wide open anterior fontanelle in all the infants, and hypocalcemic convulsions were also present concomitantly in around 50%, 7 out of 15. And when we look at their lab findings, total calcium 5.4, magnesium normal, phosphorus normal, alkaline phosphatase significantly elevated, vitamin D levels in nanomoles per liter, it was close to 30, median was 30, ranging from 12.5 to 62.5. So one had normal vitamin D level, and in fact one of the babies had hypoparathyroidism, but otherwise rest 14 out of 15 had elevated parathormone levels. Chest X-ray showed a CT ratio which was high, it was 65, normal is around 55 to 60. Corrected QT interval, which is the way how we look at hypocalcemia in ECG. So it was 0.52, normal is around 0.4, and left ventricular ejection fraction was reduced to 20%, normal is around 55%. And obviously if you find out that the cardiomyopathy is due to hypocalcemia, the treatment is very simple. You just have to give calcium and vitamin D, and the babies do really well. But of course, you can imagine that many of these babies would not be presenting to a big hospital or a tertiary care center. They would just die because of CHF, because of vitamin D deficiency. So with this data, with this background information, that we are seeing a lot of infants who are presenting with rickets, with hypocalcemic seizures and cardiomyopathy, we thought that we should do a systematic study to find out the prevalence of vitamin D deficiency in mothers and infants. And we did the study in between 2006 to 2008, and the secondary objectives were to look at the seasonal variation and the determinants of vitamin D levels in mothers and infants, and also to look at prevalence of radiological rickets in infants with 25-hydroxy-D below 25 nanomoles per liter. The reason was that whenever such work, like any work which would document that the population in general has a low vitamin D levels, any such work, if you present that, then the policy makers would say that maybe this is the norm for Indian population. It would be difficult to convince them that no, this is not the norm, this is abnormal, because they would say, why are you comparing with Western data? Maybe that's the norm for them and this is the norm for you. So we needed more harder evidence. So we did parathormone levels also in all to document if secondary hyperparathyroidism was present. We did, and we looked for radiological rickets also. So we enrolled 120 mother newborn pairs at birth, 60 in the winter, that is between November to January, and 60 in the summer, that is between April to June. And we followed them up at 3 months of age, at which time we had 47 mother-infant pairs in the winter group and 51 in the summer group. And at this time, we examined them. We took a history regarding the feeding pattern of the infant, the sun exposure, any intake of vitamin or mineral supplements by the infant and the mother. We examined them, which included anthropometry, to see if vitamin D deficiency was also associated with any growth lag or any malnutrition. And we looked at features of rickets, clinical features. And we did biochemistry, which included calcium, phosphate, alkaline phosphatase, 25-hydroxy-D, and PTH levels. And wrist X-ray was done for infants with 25-hydroxy-D, which was below 25 nanomoles. For this study, vitamin D deficiency was taken as 25-hydroxy-D below 15 nanogram per ml or below 37.5 nanomoles per liter. This was based on the recommendations in Pediatrics 2008 for vitamin D deficiency in children and infants. And severe vitamin D deficiency was taken as vitamin D below 5 nanogram per ml or below, or below 12.5 nanomoles per liter. And insufficiency was taken as 15 to 20 nanograms per ml, or between 37.5 to 50 nanomoles per liter. Elevated PTH was considered as PTH greater than 46 picogram per ml, hypocalcemia less than 9 mg per dl for infants, and high alkaline phosphatase more than 420 units per liter for infants. Baseline variables, you can see that these infants had normal birth weight around 3000 grams, which is normal birth weight for Indian infants. They were all term babies, and the time at which the sampling was done for vitamin D levels was a mean age of 13.6 weeks. 70% were exclusively breastfed. Around a third reported taking multivitamin supplements, which was containing 125 units of vitamin D2. And sun exposure, which was based on recall, the duration was around 10 minutes, median duration of around 10 minutes, ranging from 0 to 120. And a score was given based on the body surface area exposed. The maximum score was 12, and the minimum was 0. This was based on a method in which the body is divided into 4 parts. Head and neck given a score of 3, upper limbs given a score of 3, lower limbs given a score of 3, and trunk and back given a score of 3. So total maximum score possible was 12, and minimum was 0, and the median was around 4.8 for this group. Then this shows the anthropometry at 3 months, and we found that all of them had a weight, length, and head circumference which was at par with the WHO growth standards 50th centile. So none of them had any growth lag or malnutrition. For the mothers, these mothers had a normal BMI, and here it is, I want to emphasize that 98% of these mothers, because they were all being followed up at our hospital, which is a big tertiary care hospital, 98% were taking supplements of calcium and vitamin D. There is a preparation called Shell-Cal, which is used there, and it contains 500 milligram of calcium and 250 units of D2. And this was being almost universally taken, either 1 tablet or 2 tablets. So you can imagine that 250 or 500 units of vitamin D2 were taken by all, and even during lactation around 80% continued to take it. Milk intake was fairly low, less than 500 ml in more than 2/3. Sunlight exposure was not very high, only 15 minutes, and 55% were vegetarians. So what were the results that we got? In infants, mean calcium was normal, as in mothers. Mean phosphate was also normal. Mean alkaline phosphatase, as you can see, was significantly elevated in mothers as well as infants. 25-hydroxy-D, this is the mean in nanomoles per liter, 28 plus minus 20.3 for infants, and for mothers 24.8 plus minus 15. Parathormone, 67.2 plus minus 62.9. So it was, the mean was elevated for parathormone in both the groups. What about the prevalence? When we define vitamin D deficiency as less than 15 nanogram per ml, the prevalence was 66.7% in the babies and 81.1% in the mothers. And as you can see here, 1/4, more than a fourth in fact, had severe vitamin D deficiency, that is less than 12.5 nanogram per ml. These are apparently healthy, from a good socioeconomic status, infants and mothers who were all being antenatally followed and were being given supplements of vitamin D. Raised alkaline phosphatase almost ubiquitous, hypocalcemia not very common, and hyperparathyroidism in approximately 50% of the study population. And if you take 25-hydroxy-D less than 50 nanomoles per liter as a cutoff, then for infants it was 86.5% had this value, and the confidence interval was fairly narrow, 78 to 92, and for mothers 92.6% had values below 50 nanomoles per liter. So, and just to show you one more thing, that more than 75 nanomoles per liter in infants was present only in 2%, and in mothers only 1%. So like vitamin D deficiency is ubiquitous, almost everybody is vitamin D deficient. And yes, it was physiologically very relevant, because we found a very significant inverse correlation with parathormone. So as the vitamin D levels increase, parathormone goes down. Similarly for alkaline phosphatase, a very significant inverse correlation, rho of minus 0.45. Looking at seasonal variation, these low values are in these values are in nanomoles per liter, and the upper values are in nanograms per ml. These are the winter levels for infants and mothers, summer levels for infants and mothers. So in mothers there was a significant increase significant difference between the winter and summer levels. Summer levels were much higher than the winter ones, but in infants no such change was seen. Then talking about radiological rickets, out of the babies who had vitamin D levels below 25 nanomoles per liter, we were able to do X-rays in 33 babies, and out of them 10 showed evidence of early radiological rickets. As you can see in this X-ray, you can see that the ulna is showing cupping and splaying and fraying. Similarly in another X-ray. So this was really data which showed everybody that definitely the prevalence is there and it is causing problems. What were the predictors? So intake of vitamin supplement improved the vitamin D levels. So as I told you, roughly 1/3 of the babies were taking vitamin supplement, which was not very high, only 125 units, but it did increase vitamin D levels. Sunlight exposure was a significant factor. If the sunlight exposure increased, the vitamin D levels increased, and mother's 25-hydroxy D level was the most important predictor of infant's vitamin D level, as was evident in this graph also, in which a very strong linear relationship was observed between the mother's and the infant's vitamin D level. So why the high prevalence? One is that because of the skin pigmentation, as was discussed in one of the lectures in the morning, that for a Caucasian and an African American, for the same amount of vitamin D synthesis, a Caucasian would require 20 minutes, whereas the African American would require 120 minutes. So similarly, Indians have skin pigmentation in between the two, so probably they require much longer duration of sunlight exposure and greater coverage of the body. So we wear very modest clothing, and most of the women keep all parts of the body except the head and face and maybe half of the arms, forearms uncovered, and rest everything is covered. And then lesser participation in outdoor activities, particularly among girls, starting right from adolescence. And there used to be a traditional custom in India in which the babies used to be given an oil massage in the sunlight just before giving them a bath. And this was usually done by the grandmother, but now in the cities with the nuclear families coming up, this custom has gone away, and probably this is also important. None of the food items in India except infant formula are fortified with vitamin D. There is no policy of routine vitamin D supplementation either in women or in infants, no policy at all. So in our hospital it was being done because probably the treating gynecologist felt it was required, but otherwise there's no such policy. Another important factor could be that the Indian diet is low in calcium and high in phytates. And studies have shown that if a diet is low in calcium, it causes secondary hyperparathyroidism, and this causes the increased conversion of 25-hydroxy-D to polar metabolites and to 24,25-dihydroxy rather than 1,25-dihydroxy-D3. And one more study which I would like to mention here is vitamin D deficiency in rural Indian women and adolescent girls. So it was thought that probably urban Indian women are spending more and more time indoors. As we saw in the previous study, only around 15 minutes was the median time of sunlight exposure. So what's happening in rural Indian women, because they are spending more time outdoors, they are fetching water, they're working in the fields. However, in this study also, it was seen that mean 25-hydroxy-D was only 37.8 and prevalence of vitamin D deficiency was 74%. In adolescent girls, again, something similar, 88% had vitamin D deficiency. This study also compared the girls with their brothers. So 34 boys and 29 girls, they were like from the same families. They were compared, and what did you find? One was that the sun exposure was much higher in boys, because they would be playing out in the sun, they would be, more of their body surface would be uncovered, and therefore their serum 25-hydroxy-D was much higher as compared to the girls. So the girls are definitely at a disadvantage, and these are the girls who will ultimately give birth to babies with a lot of hypocalcemic problems. Vitamin D deficiency in boys only 27% compared to 89% in their sisters. And the same study also looked at seasonal variation. So I'm not sure whether you can see it. This is Jan, Feb, March, April, and so on. So the highest levels were seen in July, August, and also in May, June. So the peak was there in summer. So there was a clear trend and in summer the levels were much higher as compared to winter. Hypovitaminosis D in summer and around 54% as compared to 93% in winters. From our hospital itself, we thought that earlier we had looked at term normal birth weight, so many people felt that probably there is more and more literature emerging that low birth weight could also be related to lower vitamin D levels in the mother. So was it that our low birth weight babies are even more disadvantaged in terms of vitamin D status as compared to normal birth weight? So we did another study, and in this 220 low birth weight babies, that is less than 2500 grams, gestational age mostly borderline preterm or term babies, compared with 126 normal birth weight infants and their mothers. So what did we find? So in the low birth weight groups, the mean 25-hydroxy-D for infants and mothers for normal birth weight, again very similar. In fact, it is slightly higher in the low birth weight compared to the normal birth weight. Mothers also not much difference. And vitamin D deficiency ubiquitous, less than 50 nanomoles per liter was the cutoff, and everybody was deficient, there was no difference. But in this study also some seasonal variation was noted. So in summers for mothers also the levels were a little bit higher, and for the infants also a little bit higher, but not really significant. If you just see, these are values in nanograms per ml. So in the summer also the values would be somewhere around 15 or so. So definitely not high enough to not warrant supplementing in summers. Supplementation is required throughout the year. So other Indian studies have also documented low vitamin D levels in schoolgirls, in pregnant women, cord blood. So what about supplementation? So people have tried giving supplementation, and this study amongst schoolgirls, mean age of 12 years, they were supplemented with either 1 monthly or 2 monthly supervised dose of 60,000 units of cholecalciferol orally for 1 year. So 1 monthly dose would amount to roughly around 2,000 units of vitamin D per day, and 2 monthly dose would amount to approximately 1,000 units of vitamin D per day. And it was found that with the 2 monthly group, that is with the around 1,000 units per day group, the baseline prevalence was 94%. It decreased only to 80% at the end of 1 year of supplementation with this dose. So definitely very inadequate. Even in the 1 monthly group, so that means 2,000 units of vitamin D per day, the prevalence decreased from 88 to 57%. A significant decrease, but definitely you still had 57% which were of girls who were vitamin D deficient despite this kind of supplementation. So definitely they require much higher doses. The levels again in the 1 monthly group, they rose from 30.8 nanomoles to 49.9 nanomoles. And in this group there was much less of an increase. So the levels did increase, but definitely not very significantly, and much higher doses are probably required. Again, in the pregnant women group, many of the concerns are similar to what Dr. Hollis had said, that in India people are not really, they don't really think that if everybody has a very low level, if this is the mean level in the entire population, how can it be low? The entire population cannot be deficient. So probably that's the norm for Indians. So giving higher doses, if somebody proposes to give high doses in a trial, it is not really approved ethically very quickly. So again, very conservative kind of supplementation trials have been given. So again, in this group of 139 rural women, they made 3 groups: A, no supplementation; B, 60,000 units once in 5th month of gestation; and in C group they gave 1,20,000 units twice, that is in 5th and 7th month. And they found that a significant increase in vitamin D level occurred only in group C, from 40.1 nanomoles to 53.4. But even in group C, only 20% achieved 25-hydroxy-D more than 80 nanomoles per liter. So this dose is definitely again inadequate, even though it did lead to some increase in vitamin D levels. And one thing that I wanted to share, this is not exactly supplementation but therapy. Regarding therapy also, there are no clear-cut guidelines, and probably not in India, not elsewhere. I haven't really come across very clear-cut guidelines for therapy also. Something which has been followed very rampantly in India is called Stoss therapy. Probably you people have heard of it. It is 6 lakh units, single dose given intramuscularly. So Dr. Veet had presented some data in the morning. So it's like giving the whole year's dose in one injection. And it used to be the treatment of rickets, probably all across the world, and now also it is practiced. And what we thought that those babies who are referred to us for rickets and who already received 6 lakh units of vitamin D, we would do their levels at 3 months, 6 months and 1 year. One, to see whether they are developing any complications, and the other to look at how long are they able to maintain vitamin D levels after this single mega dose of vitamin D. So this is an ongoing kind of study, but we found that at 3 months, 4 out of 12 babies in whom we were able to take the measures at 3 months till now had hypercalcemia, that is serum calcium more than 10, and hypercalciuria was also present in these babies, and 25-hydroxy-D level were documented to be greater than 200 nanomoles per liter. And by 1 year, we have been able to follow only 5 of these babies till now, and 3 of them have got serum 25-hydroxy-D below 50. So again, it's the kind of graph that Dr. Veet had shared with us. So definitely this is not a treatment that should be practiced, but what exactly should be practiced, what should be done for prophylaxis, what should be done for treatment, these are questions which definitely require further research. Thank you.
Thank you so much. Any questions?
That was very interesting. You mentioned that an Indian diet is low in calcium, and I was just wondering whether that's a traditional Indian diet or an urbanized Indian diet, because I think the African diet is low in calcium in the African people migrating to the UK, and I'm not sure whether that's shifts from foods they would have included back home. I think both diets tend to be low in dairy products in the countries of origin. But possibly the calcium would normally be made up from pulses and that sort of food. What's your view?
Calcium predominantly comes from dairy products only, and the intake is really low in rural areas as well as urban areas. So it's not really related to urbanization, though of course in rural areas people have cattle at home. So the milk intake is likely to be more, but again there is a problem there that many times people tend to give milk products to boys in the family but not to girls. So that situation is also there, and definitely calcium intake in women and girls is not up to the mark at all.
Would vegetarianism play a role also in the traditional Indian diet, associated with Hindu religion, and also the fact that clearly they probably won't be eating any oily fish?
Yeah, I don't think people eat any oily fish in India. I myself am a vegetarian. Vegetarianism is very common. Even in so-called non-vegetarians, the intake of non-vegetarian food would be like once or twice in a week. That would be mostly chicken. So oily fish and all would be a rarity. Very few people would eat it. Probably some in the southern peninsula region, in the coastal areas, some people would eat it, but definitely nowhere in the north. Thank you.